Imagine a tiny, like completely hidden piece of cartilage in your knee.
Right, just tucked away in the
Yeah,
back.
exactly. And if a surgeon overlooks it, it can single-handedly destroy a flawless, multi-thousand-dollar ACL reconstruction.
Which is a pretty terrifying thought for anyone who's had knee surgery.
Oh, absolutely. So to kind of visualize this, I want you to imagine the room darkening around you and this high-tech, glowing blueprint of a human knee joint just materializes in midair.
Oh, I like that.
Yeah, right. And every ligament, every bone contour, every microscopic fiber of cartilage is illuminated in the sharp, perfect detail. And as this holographic knee slowly rotates, we're going to hunt for a phantom.
Because, I mean, the knee is essentially a biological suspension bridge.
Okay, a suspension bridge.
Yeah, it relies on this perfect balance of tension and compression. So when a single, millimeter-wide tether snaps in the absolute darkest corner of that joint, the entire biomechanical system just begins to destabilize.
Which brings us to the roadmap for our hunt today. We're doing a deep dive into a really fascinating 2025 special series review published in the American Journal of Röntgenology.
It's a fantastic paper.
It really is. And the text focuses on a structural failure with a very dense multi-syllabic name. It's the Posteromedial Meniscocapsular ramp lesion.
Quite a mouthful.
Yeah, try saying that 3 times fast. But our mission in this deep dive is to basically translate this really rigorous medical literature into the underlying biomechanical physics.
Right, because the clinical stakes here are just massive.
They really are. We're examining the surprising limits of modern medical imaging, the cellular biology of how we heal, and honestly how orthopedic surgeons are operating as physical detectives to find these injuries that actively hide from them.
Exactly. We're talking about an injury that sabotages a patient's recovery, often without the patient or the surgeon ever even realizing it until the knee fails a second time.
Which is wild. So whether you're an athlete or maybe someone who has endured the grueling rehab of a torn ACL, or you're just a learner who's fascinated by the structural limits of the human body under extreme load, this mechanical cascade is just gripping.
It really is. The review shows how a minuscule, often totally invisible structural failure creates this massive chain reaction.
Okay, let's unpack this. Let's break down the anatomy of the lesion itself, because posteromedial meniscocapsular ramp lesion sounds intimidating, but it's really just a very precise geographic and structural coordinate.
Right. So posteromedial just refers to the extreme back inside corner of the knee compartment.
Okay.
And the meniscus itself, that's a dense fibrocartilaginous tissue. We are specifically looking at the posterior horn of the medial meniscus, which doctors usually just abbreviate as the PHMM.
PHMM, got
Yeah.
it.
And this structure doesn't just rest passively on the tibial plateau. It is locked down, under very high tension, by 2 crucial fascial attachments.
Right, so you have the meniscocapsular attachment, which kind of weaves the meniscus upward into the lining of the joint capsule.
Exactly.
And then you've got the meniscotibial attachment, which firmly anchors the underside of the meniscus directly into the bone of the tibia.
Spot on. So a ramp lesion is basically a tearing of these specific tethers, or a tear at the extreme outer edge where the meniscus meets the capsule.
And the historical context here is wild. The review mentions a surgeon named Strobel who actually dubbed these hidden lesions way back in 1998.
Yeah, because standard arthroscopic techniques simply could not spot them.
Right, like looking through routine camera portals at the front of the knee, the surgeon's line of sight is just completely blocked by the massive curvature of the femoral condyle.
It's basically like you're trying to inspect the back wall of a room while standing in the front doorway, but there's this massive, solid pillar right in the middle blocking your view.
That is a perfect way to picture it. And because the anatomy naturally hides this corner, these tears just went underreported for decades.
For a very long time, yeah.
So to kind of visualize the mechanical consequences of losing this hidden structure, let's think about the relationship between your anterior cruciate ligament, the ACL, and this specific meniscus structure.
Let's do it.
I like to think of it like this. If your ACL is the heavy-duty parking brake, keeping your shin bone from sliding too far forward, then the posterior horn of the meniscus acts like those heavy rubber wheel chocks that you'd wedge tightly behind the tires of a truck.
I love that analogy. It's incredibly accurate. The ACL is your primary restraint against anterior tibial translation.
Right.
The meniscus and its attachments are the critical secondary stabilizers. So when the ACL ruptures during a trauma, the tibia violently shifts forward.
And if the tibia shifts forward, but the thigh bone stays in place, that meniscus just gets totally trapped.
It gets wedged. The review actually points out that when the knee loses its primary ACL stabilization, the mechanical force exerted on the posterior horn of the medial meniscus effectively triples. Triples. The curved geometry of the femur just grinds against the flat plateau of the tibia, and that little fibrocartilage wedge has to absorb this immense, unnatural load trying to halt the slide.
I mean, 3 times the normal physical force is just a massive mechanical overload. If those tethers snap under the pressure, basically the wheel chocks are kicked out from under the tire.
Exactly. And the clinical danger of this doesn't show up immediately. It materializes months later in the operating room.
Right, because the surgeon builds this pristine new ACL graft for the patient.
But if they fail to identify and repair that meniscocapsular ramp lesion, the knee doesn't have its secondary stabilizer.
So the moment the patient begins rehab, all those tripled strain forces are basically just bypassed entirely and shifted directly onto the brand new healing ACL graft.
Which is exactly why so many grafts fail. The constant mechanical stress vastly increases the likelihood that the graft will stretch out, become lax, or just catastrophically rupture again.
And given that an intact graft depends entirely on having an intact meniscal wedge, the obvious clinical imperative is to find these tears before the surgeon even makes the first incision.
You think so, yes.
But the literature reveals this stunning technological failure in how we actually visualize these injuries.
Yeah, it's fascinating. The physics of our primary diagnostic tool clashes directly with the anatomy of the injury itself.
Right, because MRI magnetic resonance imaging is globally recognized as the gold standard for soft tissue diagnostics in the knee.
Without a doubt.
But the data in this 2025 review highlights a massive blind spot. The MRI only demonstrates a 70% pooled sensitivity for identifying ramp lesions in ACL-deficient knees.
Which is a huge problem.
I mean, 70%, meaning across all the major studies analyzed, the MRI flat out misses these specific tiers 30% of the time. Contrast that with a 93% sensitivity for spotting regular mid-body medial meniscus tears.
And missing 1 out of every 3 structural failures is just an unacceptable margin of error when the survival of the ACL reconstruction absolutely depends on it.
Wait a minute, though. We have these 3 Tesla state-of-the-art MRI machines utilizing immense magnetic fields, radio frequency pulses, mapping water molecules at a microscopic level.
Oh, the tech is incredible.
So how does a multi-million-dollar imaging suite simply fail to see a torn ligament in a third of the patients?
This raises an important question, and the answer is that the failure is not in the software or the magnetic field strength at all.
Okay, then what is it?
It is a limitation of physical posturing. When a patient is placed into an MRI scanner, their leg is secured inside a dedicated cylindrical knee coil.
Right.
To fit inside this coil, the leg has to be locked into full or near full extension. The leg is perfectly straight.
Okay. And locking the joint in extension physically compresses the posterior compartment. And radiologists, they rely on the presence of fluid to identify a tear, right?
Exactly. In certain MRI sequences, fluid shows up as this bright white signal, which contrasts really sharply against the dark, dense tissue of the meniscus.
But when the knee is locked straight, the torn tissues at the back of the knee are violently pressed together. The joint space is just obliterated.
Right. Because the tissue is completely compressed, synovial fluid literally does not have the physical volume to pool into the microscopic gaps of the meniscocapsular recess.
It's kind of the equivalent of pressing 2 soaking wet sponges tightly together.
That's a great way to put it.
Like, as long as you are physically squeezing them, you can't see the individual pores or the space between them. You only see the gap if you release the pressure and let the sponges pull apart.
Exactly. Because the leg is strapped down flat, the tear is squished completely shut, which masks the bright fluid signal the radiologist is desperately searching for.
That is wild.
And there's an additional layer of biological interference the review describes, which is known as phantom healing.
Phantom healing.
Yeah. The timing of the scan actually plays a major role in its accuracy.
So phantom healing basically suggests the MRI is technically capturing the anatomy correctly at the time of the scan, but the biology actively alters the evidence before the surgeon ever opens the knee.
Precisely. See, the meniscocapsular junction is located in what orthopedic surgeons call the red zone.
The red zone, meaning it has blood flow.
Heavily vascularized, yes. Supplied by a dense network of blood vessels called the genicular artery capillary plexus.
Oh, wow. Okay.
And because healthcare logistics often dictate a delay of several weeks or even months between the initial MRI and the actual surgical intervention, stable ramp tears have time to interact with this rich blood supply.
So the body basically throws down biological spackle.
Hmm.
The rich vascularity allows this spontaneous regional healing to occur in the waiting period.
Exactly. The acute fluid-filled hemorrhagic tear that was captured on the initial MRI begins to organize into fibrotic scar tissue.
Okay.
So by the time the surgeon is physically inside the joint, what initially appeared as a clear, bright white fluid signal separation might simply present as dark, low-signal strands of tough scar tissue.
So if the diagnostic imaging is blinded by the straight leg posture, and then it's further confused by the patient's own genicular arteries depositing scar tissue, the surgical team really cannot rely on the radiology report alone.
They cannot. They need a predictive model. They need to know the specific profile of a knee that is highly likely to be hiding a ramp lesion.
So let's look at that profile. The researchers analyzed 45 different potential risk factors across various cohorts, and the prevalence is startling.
Very high.
Yeah, depending on the specific study parameters, between 9% and 42% of patients with an ACL rupture harbor a concomitant ramp lesion.
Almost half in some cohorts.
Right. So let's isolate the heavy hitters from that data set. First, the presence of a complete ACL rupture makes a ramp lesion 8 times more likely to occur than in a knee with only a partial ACL tear.
Which makes sense mechanically. A complete rupture implies a massive transfer of high-energy, uncontrolled force through the joint.
It's just a bigger explosion.
Exactly. It's easily sufficient to snap those secondary posterior tethers. Additional highly correlated risk factors include male sex, a simultaneous lateral meniscal tear on the opposite side of the joint, and the presence of severe bone contusions.
The bone contusions are fascinating from a physics perspective.
They really are.
The review notes these show up as geographic regions of low signal on T1-weighted MRI images. They are essentially bruises deep inside the bone marrow.
Right.
This happens through a pivot shift mechanism during the trauma. The ligaments fail, the joint subluxates or shifts out of position, and the dense bone of the lateral femoral condyle violently impacts the back edge of the tibia.
Yeah, and if the impact force is severe enough to literally crush the trabecular bone and cause marrow edema, the kinetic energy transferred through the joint has almost certainly overwhelmed the tensile limits of those meniscocapsular ligaments.
Okay, that makes total sense. Now, the review also highlights a critical chronicity factor.
This is a huge point.
The likelihood of developing a ramp lesion steadily increases the longer a patient delays their ACL reconstruction, and it plateaus at around the 24-month mark. This completely reframes the injury for me. It's not exclusively caused by the initial traumatic impact.
What's fascinating here is that the timeline reveals a mechanism of progressive structural fatigue. When a patient continues to bear weight and walk around without an intact ACL, the knee experiences this chronic, microscopic instability.
It's the mechanical equivalent of driving a car with a misaligned tire.
Exactly.
Like the initial pothole bends the rim, but it's the thousands of miles driven on the wobbly, unbalanced wheel that slowly shreds the surrounding rubber of the tire.
That's spot on. Every single step the patient takes allows a tiny, abnormal anterior shift of the tibia.
Wow.
And this repetitive shifting acts like a wedge, chronically stretching, fatiguing, and eventually tearing the posteromedial meniscus tissues through shear cyclic loading.
So if a patient matches this high-risk profile, like presenting with a complete ACL rupture, deep bone marrow edema on the MRI, and let's say a 6-month delay since the initial injury, the surgeon goes into the operating room with the absolute assumption that a ramp lesion exists.
They have to. They completely disregard a negative MRI report.
Okay, so this is the showdown. The surgeon transitions from relying on imaging to actively hunting for the lesion in the OR using advanced arthroscopic techniques. And accessing this dark corner of the joint requires some aggressive maneuvering.
It really does.
The text details the primary visual approach, known as the modified Gilchrist view.
Yes.
So the surgeon takes an arthroscope equipped with a 70-degree angled lens, threads it through the front of the knee, navigates it through the tight intercondylar notch, slips past the massive medial femoral condyle, and then basically rotates the lens to look backward into the posteromedial compartment.
Navigating the camera is only the first hurdle. Often the tissue is so tightly packed that even with a 70-degree lens, the surgeon simply cannot visualize the meniscocapsular junction,
Right.
which requires a secondary technique called trephination.
Trephination, also known as pie crusting, which involves the surgeon taking an 18-gauge spinal needle and repeatedly puncturing the deep medial collateral ligament from the outside of the knee.
Yes.
But wait, poking holes in a ligament seems completely counterproductive when you're trying to fix a joint. What is the mechanical logic behind intentionally damaging the MCL just to see a meniscus tear?
It sounds crazy, but the deep medial collateral ligament is composed of these highly tensioned, parallel bundles of collagen fibers that hold the medial compartment tightly shut.
Okay.
By using a needle to puncture tiny, precise holes in the ligament, the surgeon micro-releases the tension in those specific collagen bundles. It does not destroy the ligament's overall integrity, but it creates just enough localized laxity to allow the joint space to stretch open a few extra millimeters.
Oh, wow.
Yeah, and that tiny window of laxity allows the camera to slip past the condyle and visualize the hidden lesion.
That is so clever. Okay, so once visual confirmation is established, the clinical algorithm basically diverges. Because simply finding the tear doesn't automatically dictate the treatment.
Right.
You have to determine its stability. But determining stability inside a fluid-filled joint space sounds incredibly subjective. How does a surgeon actually measure structural stability mechanically?
They utilize a tactile diagnostic tool. They insert a specialized blunt metal hook into the posterior compartment. They physically hook the posterior horn of the medial meniscus and apply anterior traction.
They literally just tug on
They
it.
tug on it.
Yeah.
If the fiber cartilage easily displaces anteriorly into the joint space, pulling away from the capsule, the tear is classified as unstable.
So what does this all mean? An unstable lesion means the tethers are completely non-functional.
Yes.
The wheel chock is totally disconnected.
Exactly. And the medical consensus for an unstable lesion is absolute. It must be surgically repaired. Leaving an unstable ramp lesion virtually guarantees the failure of the ACL reconstruction.
Right, so the surgeon establishes an accessory posteromedial portal, like a separate incision at the back of the knee,
Correct.
and they utilize a hook-type suture passer to shuttle high-strength polymer threads through the torn tissue, physically tying the meniscus back down to the joint capsule.
And this biomechanical restoration is highly effective. The literature indicates the re-tear rate drops to less than 7% following a proper suture repair.
Which is amazing. However, the most counterintuitive protocol in the entire review involves the treatment of a mechanically stable tear.
This is where biology meets mechanics. A stable tear occurs when the surgeon hooks the meniscus and applies traction, but the tissue does not displace.
Okay.
The structural integrity is compromised, but the wheel chock remains firmly lodged in place.
So let me get this straight. The surgeon has utilized a 70-degree lens. They've pie-crusted the MCL with a needle to gain access. They've identified a tear and probed it. Yet, because the tissue resists the pull of the probe, the clinical recommendation is often to just leave the structural tear entirely alone.
Sometimes, yes, or to perform a procedure known as cortical abrasion. They take a motorized rasp and intentionally scuff up the edges of the stable tear and the adjacent synovial capsule.
Okay, intentionally causing microtrauma to a stable lesion. Oh, this harnesses the unique cellular biology of the posterior knee that we talked about earlier.
You got it. We discussed the genicular artery capillary plexus and how its rich blood supply causes that phantom healing that confuses MRIs.
Right.
Well, the surgeon is essentially weaponizing that exact biological mechanism.
That is brilliant. By using a rasp to rough up the highly vascularized tissue, the surgeon intentionally inflicts acute trauma to trigger a localized inflammatory cascade.
Exactly. The abrasion causes the tissue to bleed into the microscopic gaps of the tear. This blood forms a fibrin clot packed with platelets, macrophages, and intrinsic growth factors.
Wow.
And because the tear is mechanically stable, meaning the physical forces of the knee aren't going to constantly pull the healing edges apart, the biological spackle is allowed to harden.
And the body's natural cellular machinery infiltrates the fibrin clot and synthesizes new collagen, essentially gluing the stable tear back together with stronger fibrotic scar tissue.
The body operates as its own structural engineer, provided the mechanical scaffolding remains stable enough for the cells to actually do their work.
It's incredible. This whole deep dive into the posteromedial meniscocapsular ramp lesion really exposes a remarkable intersection of biomechanics and cellular biology.
It really does.
It's this tiny, localized failure that multiplies mechanical force, destroys surrounding grafts, hides from advanced magnetic imaging through postural compression, and forces surgeons to rely on tension-releasing needle punctures and tactile metal probes just to decide whether to deploy polymer sutures or trigger a blood clot.
The anatomical complexity demands a level of clinical suspicion that really supersedes our reliance on static orthostatic technology.
Absolutely.
And the review offers a final data-driven revelation that challenges the very foundation of how we utilize that technology.
Yes, the 2025 data points toward an actual mechanical solution for the MRI's blind spot.
Right. Standard MRIs force the knee into full extension, compressing the lesion and dropping diagnostic sensitivity to 70%. But the review cites recent biomechanical imaging studies where researchers simply altered the physical posture of the patient.
Okay.
They placed the patient's knee in 90 degrees and even up to 120 degrees of active flexion inside the MRI scanner.
They literally just bent the knee while taking the images.
So bend the knee. And by bending the knee, the posterior femoral condyle rolls backward, and the mechanical compression on the posteromedial compartment is released. The torn tissues are pulled apart, allowing the synovial fluid to pool into the meniscocapsular recesses.
And what were the numbers?
With the knee inflection, the diagnostic sensitivity of the MRI jumped to a staggering 92%.
That is insane. A 22% increase in diagnostic accuracy simply by acknowledging the dynamic biomechanics of the joint space.
Exactly. And it forces us to ask a much broader physiological question for you to mull over.
Oh, I like where this is going.
If we are failing to identify up to 30% of critical joint-destroying structural failures simply because we mandate that patients lie perfectly flat and straight inside a narrow magnetic tube, how many other mechanical injuries across the human body are we completely overlooking?
Wow.
Are we missing subtle instability in the shoulders, the cervical spine, or the hips? Simply because modern medicine continues to design its diagnostic imaging around the static, rigid shape of the machine, rather than the dynamic, kinetic reality of the human body.
That is a phenomenal question. The holographic blueprint of the knee we visualized earlier is a static image, but the human body is an engine of constant motion. It appears our diagnostic tools and the way we use them really must begin to reflect that dynamic reality.
Couldn't agree more.
Well, the hunt for the hidden lesion requires us to rethink not just where we look, but how we look. To everyone listening, keep asking critical questions, keep challenging the limitations of the tools around you, and as always, stay insanely curious.